Assalamu alaikum, good afternoon, good morning, wherever you are joining us from different parts of the world. A very, very warm welcome to each of you joining us today for the Health and You Community Wellness Series. I'm Dr. Sohaila Chima. I'm the Assistant Dean for the Institute for Population Health here at Weill Cornell Medicine-Qatar, and also an Associate Professor of Clinical Population Health Sciences. So we would like to again warmly welcome each of you. As many of you who attended the series in the past, the overall goal of the series is really to create community awareness about health and disease. And what we really want to try and achieve by these sessions is to enhance self-care, reduce suffering, improve the quality of life, and increase healthy longevity. We would also like to reiterate again that this is not a CME CPD activity. There will be no certificates issued for this. This is for the general public, so just be mindful of that. Just some housekeeping. Your cameras and microphones have been turned off. For the Q&A, the question and answers, you can just either post your questions in the Q&A tab, or you can also type in your questions, comments in the chat. So we will be able to see those comments and questions, and we will address them at the end of the session, and I will be there to moderate the session with Dr. Huckell. Again, a reminder, this is not a CME CPD activity and no certificates of attendance will be issued. So I'm really excited about this session today. We have a great expert speaker today joining us, and we would really like to thank Dr. Caitlin Huckell for doing this session today. So she's going to be talking about menopause, a practical review and discussion of treatment options. It is really my honor to introduce Dr. Huckell. She's the co-director of the Obstetrics and Gynecology Clerkship at Weill Cornell Medicine-Qatar. She's a member of the Royal College of Physicians and Surgeons of Canada, and she's been a consultant for 20 years. In addition to her interest in menopause, she focuses clinically on adolescent and pediatric gynecology, having opened the first pediatric gynecology clinic in Qatar at Sidra Medicine in 2018. So please join me in welcoming Dr. Huckell to the session today. Dr. Huckell, over to you and a very warm welcome.
Thank you very much. I'm really looking forward to the talk today. I'm just going to screen share and we'll get ourselves organized here. Okay, here we go. Can everyone see okay?
Yes.
Perfect. All right, so thank you very much. It's my pleasure today to speak to the community on menopause. The talk today, just so everyone knows, is going to be not so medicalized because I really want everyone to have a basic understanding of what menopause is and ways that we can help ourselves feel a little bit better as we go through this transition in our life. As noted, I am working at Sidra currently in pediatric and adolescent gynecology, but throughout my career, I have done a great deal of work in the menopause community as well. All right, so the talk today, I just want to preface with saying that menopause is simple in terms of the biology, but complicated in terms of the management. And part of the reason that it is complicated is basically all women around the world are a little bit different about how they feel about things, about how their biology works and how they transition through menopause. So it's not easy to make a simple solution for women overall. And this is why it becomes very complicated, because menopause care really needs to be individualized for each individual woman. Now, why do we talk about menopause, or why is it even a current issue that we worry about? People can make a really good argument that menopause is not a disease. It's a normal biological change that happens to all women. It's not something that a woman can avoid, and it's actually part of nature. So why do we talk about it? Why is it something that has fallen into the medical communicate if it's not a disease, something that we have to treat in a medical manner? Well, it becomes important because although menopause itself is a normal phase of life, what menopause does to the female body is not necessarily so normal for all women. A strict definition, or the medical definition of menopause, is when a woman does not have a period for 12 months. So 1 year without a menstrual cycle makes the definition of menopause. And simply, what is happening with menopause is the ovaries are aging, they stop releasing eggs. As the eggs are no longer being released, the estrogen in the female body starts to decline. And you can kind of see from the little pictograph in the bottom of the screen here that after we go through puberty, start being early in our 20s, estrogen is still increasing. We hit our estrogen peak at about 35 and then starts to decline down into about the age of 50 or 51. We do still have some estrogen in our late 50s and early 60s, but as a woman gets older and older, the component of estrogen, her natural estrogen, becomes less and less. And so really menopause, by definition, is a decline in estrogen. Now, the reason this is difficult for women is that we tend to think of estrogen or female hormones as those hormones that allow the eggs to be released, to allow us to have our families, to have children. But it's not really as simple as that. Almost every single female body organ has estrogen receptors from the top of our body all the way down. Estrogen is significant in our brain for helping our body temperature adjustment stay normal. It helps with how the brain functions, for memory function. It has an impact on sexual health and brain component of sexual interest. Estrogen works in our liver to help us make good cholesterol and fight off bad cholesterol. It makes our bones dense. It reduces our risk of osteoporosis. It keeps our skin plump. And it also has a significant effect on how our heart is working and how our blood vessels are working. Of course, it affects the female organs, the breast, the ovaries, and the uterus, but these organs become less important after menopause, and the other organs, especially the liver, the brain, and the heart, become really significant after menopause because of the lack of estrogen. Now, as women go through menopause, yes, it's a really natural time of life, but over 80% of women experience some symptoms. Experiencing a symptom doesn't mean that it bothers you. It just means that you've noticed that something is changing. But at least 80% of women do notice in their 50s or late 40s that something feels different, that something is changing for them. Now, why is this important? Like, why do we even notice this now? Well, it's really because due to improved social conditions, cleanliness, determinants of disease, and healthcare, that women's life expectancy has increased dramatically. If you go way, way back in time, if you go back to like 5000 BC, most people, male and female, lived to about 25 and 30. This was pretty normal. So it didn't really matter much what happened after that, what happened with menopause. But as we got more and more through time, so you can see that this graph starts about 1840 and moves up here to projected life expectancy in 2040. And each one of these different colors represents a different country. But on average, you can see that women's life expectancy has dramatically increased. It's almost a linear increase from the late 1800s into what we are thinking in 2040, which isn't really that far away. So as women are living longer, we no longer live to 25 and 30 years. Most of us are going to hit 70 years. Many of us are going to hit our 90s, and more people are going to start becoming 100 years old. We're seeing more and more people around the world, both men and women, live to 100 years old. Of course, the issue is, if we're going to live this long, we want to live well. We want to continue to feel healthy and active and have as much enjoyment of our life as we can when we are 90 as when we did when we were 20. Now, some issues about menopause. So menopause by the numbers. So what I wanted to point out to everyone is that 100% of women will experience menopause at some point of their life. It is a medical entity that is not avoidable. There are many things in medicine we can avoid, but menopause is absolutely unavoidable. 100% of women will experience menopause. The average age of menopause is 51, but you can see that the age of perimenopause, it can be sort of an 8 to 10 year process in our late 40s when the estrogen starts to decline and we are noticing the symptoms. And for most people, 8 to 10 years, so if you think about a decade is a really long time to have things changing in your body, to have to cope with these signs and symptoms. So what happened? Why are we so concerned now about menopause and treating and managing menopause? Really interestingly, HRT was first invented, or hormones were first invented and widely prescribed in the 1960s. And from the 1960s until actually the early 2000s, women were happily using hormone replacement therapy. No real concerns. They started to feel hot flashes or unwell. They went to their doctor and they got a prescription. So women were happily using HRT until about 2002. But then what happened in 2002 and 2003, actually within months of each other, two very significant studies were released in the world. The one in the United States was called the Women's Health Initiative, WHI, and in the UK, the one was called the Million Women Study, and they were literally released within about 6 months of each other. And these studies caused basically a medical panic within the community of physicians who care for women, because the data from both of these studies, and these were huge studies, they had a huge number of patients enrolled, and they were able to pull out a great deal of data that looked really important and really valid. So the data seemed to suggest that there was a much higher rate of breast cancer and stroke for women using HRT than was previously thought. And because the studies showed such significant outcomes and they were released so close together, there was a great deal of publicity in 2002 and 2003. And there was really significant public concern that so many women since the 1960s had been getting hormone replacement therapy. And there were advisories worldwide that women were advised to cease HRT use immediately. Just go cold turkey, stop it right away. Physicians were advised to recall all patients that they had prescribed HRT to, and go through the charts, bring these patients in, counsel them that they must stop immediately. And then moving forward, we were told no more should we ever prescribe hormone replacement to postmenopausal women or women struggling with menopausal issues. And by early 2005, which was basically a year, so the 2003, 2004, hormone prescriptions dropped by about 80%. So in 1992, the two most prescribed medicines in the world were antibiotics and hormone replacement. By 2005, many drug companies were pondering or considering stopping production of hormones altogether, because an 80% drop in prescriptions, it had no validity to the hormone companies or to the pharmaceutical companies anymore to produce this. So then, after 2005, it wasn't prescribed anymore. And we had a whole bunch of women who were suffering terribly from menopausal symptoms. But what the studies really showed, so what really happened when the studies were more carefully reviewed after all of the global and medical panic, is that yes, both studies did show that there was risk for a very special population of women. So women over the age of 60, and those women who started HRT 60 and over, or who started menopause more than 10 years, started hormone replacement therapy more than 10 years from menopause, so 1 year without periods, there was increased risk for this group. But if you think about it for a little bit, this is not the typical group of women seeking HRT for symptom management. Most women, they start their menopause about 50 or 51. Maybe they struggled when they were 48. Maybe they're struggling when they're 52. Most women don't wake up when they're 60 years old and think, you know what, today's the day that I'm going to start my hormone replacement therapy. I'm 60. I think it's a good day to start. So all of the panic and the changes in prescribing and pharmacology production really was kind of wrong. But we had been left for many years with the history of these studies from the early 2000s, that people, when they Google search or when they talk to the mom, people are still hit with this information that, no, do not take hormone replacement therapy. You're going to get breast cancer. No, do not use that. You're going to give yourself a stroke. And so we are still struggling a little bit to combat what is the public thinking versus what the actual medical knowledge of hormone replacement therapy is. Now, it is menopause is a time when there's many memes in the world. So, people can go online, they make jokes. Hot flashes are my new cardio. I'm forgetting things all of the time. Or, I'm so hot, I'm sitting in the fridge. And so it is human nature to make light of something that is actually very difficult. So there's so many menopausal jokes online, but the truth is, for most women, about 70% of women, menopause is not a joke. We make light of it because it is a difficult time, but it is also a very difficult time for many women. About 70% of women, when we do good studies in the menopausal population, they will report that their menopausal symptoms have had a moderate or severe impact on the quality of their life. And these symptoms can impact at work. So they have memory loss, they can have anxiety, they have difficulty leaving the house, they have mood disruption, or they can have symptoms that are physical. So they are flushing, they are hot, they are getting more and more sleep deprived because of insomnia. So 70% of women actually have significant impact from menopausal symptoms. Now, all of the symptoms, some people would consider these symptoms significant and some people not so much. In addition to those other problems, people can just feel irritable. They can have more headaches. They can have a loss of sexual interest, loss of relationship with their partner. And also, people can start getting really joint pain, really achy, having difficulty attending to their task or doing exercise that they previously enjoyed doing, or going out with their family. So these are symptoms, things that patients notice. And then there are signs, things that we can document or patients are noticing as well. So it's fairly typical around menopause with hormonal fluctuations that there is weight gain. People start to notice that their skin is a bit more saggy or more dry. They can have sore or tender breasts or a sensation of breast enlargement, and they can have vaginal dryness, sort of that can translate to sexual discomfort with their partner. It can also translate to having more difficulties with urination, feeling uncomfortable when they go to the bathroom, or a sensation of burning when they pee. So all of these are signs and symptoms that women can have. Some women may have none of these. Some women may have two of these. Some women may have all of these. There is no predictor for an individual woman when she's like 40 or 45, and she'll ask you, doctor, how will menopause be for me? You actually have no way of predicting how affected a woman will be until she gets there. And then she will report to you how affected she is. Now, of course, women, regardless of whether they're 25 or 50 or 55 or 60, they really want to feel better. Historically, we knew as physicians that giving hormones made people feel better. There is really strong research and lots of clinical trials that support that the use of hormones will definitely improve the hot flashes, the night sweats, the sleeping, the mood. It also lowers rates of cardiovascular disease and lowers rates of fractures. So we all sort of, might have a family history of one of our elderly grandmothers or an aunt who will fall and break her hip. People who have used hormone replacement therapy have a reduced risk of these older age fractures. Now, we still don't know everything about hormone replacement therapy, and there's lots of things being researched, but it suggests that people who do use hormone replacement therapy have a decreased chance of development of dementia or Alzheimer's. They have improved or maintenance of their memory, a reduced chance of diabetes, which links a little bit to reduced or decrease in the abdominal fat that women tend to note comes along with menopause. Okay, but HRT, it seems like a good thing, right? It's like I'm selling it, but I'm not. So HRT is not suitable for everyone. So there are definitely women who it's absolutely contraindicated. We should not be using it. And it's a small group, but it's an important group. So any women who have vaginal or genital bleeding without a diagnosis, we don't know why she's bleeding, she should not be prescribed hormone replacement therapy. People who have a history of an estrogen-dependent cancer, these are most commonly breast cancers, but can also be uterine cancers or endometrial cancers. A woman who has had a personal history of breast cancer, And I put the bracket here, systemic HRT, which I'll talk about a little bit later, but systemic means it goes through the whole body. You're using a medicine that is involving the whole body. There are some hormone replacement treatments that we can offer menopausal women that work locally. They work just in the vaginal tissues or just in a few other tissues, which are probably safe for breast cancer, and I'll go over those in a little bit. Women who've had a history of a pulmonary embolism or a deep vein thrombosis, a woman who has previously had a stroke or an MI or a heart attack, a myocardial infarction, women with active liver disease, and of course, someone who is unexpectedly pregnant around the age of menopause should definitely not get hormone replacement therapy. So people will say, are there non-hormonal options? Yes, of course there are non-hormonal options. I'll talk about them briefly, but mostly today we'll focus on hormones because of the controversies. So non-hormonal options can include simple things like cognitive behavioral therapy, hypnotherapy, herbal supplements, increasing exercise. And then there are people who will use plant estrogens. You would often find this at a health food store. They tend to have names like Swedish Mist or St. John's wort. These are herbal supplements that are formulated for menopause or black cohosh. They have those sorts of names. There are also some prescribed medicines that are not hormones. So gabapentin is an anti-epileptic medicine that does seem to work to reduce hot flashes a little bit. There's a medicine called clonidine, and then some of the antidepressants will also work to reduce hot flashes. But of course, all of these prescribed medications, although they are not hormonal, do have some side effects, such as increasing blood pressure, changing mood in a bad way rather than a good way. So when women want to choose non-hormonal options, it requires a slightly different bit of counseling. All right. So I wanted to talk just specifically today about hormonal options. As we noticed from the previous slides, hormonal options will definitely improve all symptoms. They are highly effective, and they definitely have long-term benefits for reducing osteoporosis and older age fracture risk, for reducing heart disease, for improving one's life quality, and for maintaining or improving cognitive function with a probable reduction in development of dementia and or Alzheimer's. Okay. But if we are prescribing hormone replacement therapy, knowing all of the good things that it does for our patients, we still have to know that there are potential risks, like anything in the world. So the big three risks we worry about are indeed stroke, development of blood clots, and development or exacerbation of breast cancer that we don't know is already there. So some of the newer studies suggested that there is actually no increased risk of stroke if HRT is started within 5 years of menopause. And this goes back to those two really big studies that made everybody scared. But those stroke risks were people who started at the age of 60, presumably 10 years or more after menopause. And in fact, we know that if it started within 5 years of menopause, it actually may be protective to stroke. And if people stop the HRT, they've used it for 3 or 4 years, they feel better, they decide to stop it, there's no ongoing risk. They potentially had a smaller increased risk while using it, but they stopped it, their risk goes back to baseline. Now, blood clots are kind of the same in that if HRT is started really close to the onset of menopause, it doesn't appear to increase risk of blood clots or clots in the legs. And if a woman is healthy and active, there's even a lower risk for healthy active women. And the different ways of using estrogen, so pills and tablets, there's a type of patch that is used, and the patch actually seems to reduce the risk of blood clots in a positive way. Breast cancer, which was what the WHI made everyone scared about, it appears to be significant only after people have used hormone replacement therapies for 10 years in a row. And of those 10 years in a row, only hormone replacement therapies that contained estrogen and progesterone together. There are a small group of women who use only estrogen for hormone replacement, and those women, interestingly, do not have any higher risk of breast cancer. So now, types of hormone replacement therapy. Normally, we think about two hormones for HRT. So we use estrogen in combination with progesterone. Now, estrogen is the one that basically provides all of the benefits of HRT use. It binds to our receptors in our brain, into our liver, into our heart. It binds to all of the estrogen receptors and makes those organs function better or function more normally because the estrogen is there. For women who have a uterus, which is the majority of women going through menopause, we have to use another hormone called progesterone. And why do we have to use this? We have to use this only because the uterus likes estrogen. It doesn't know it's 55 years old if you give it estrogen. And the lining of the uterus will continue to grow and develop. And if there is no progesterone to help this lining not develop, then the lining inside the uterus with estrogen alone will develop into an endometrial cancer or a cancer of the uterus. So the data we have that estrogen alone doesn't cause increased risk of breast cancer if it is used without progesterone are from women that have had their uterus removed. So they've either had fibroids, they've had heavy bleeding, they've had some reason to have their uterus removed. But this is a really small population of women. Almost all women going through menopause will have a uterus and they need to have estrogen and progesterone. Now, those of you who are paying attention closely to the slides will notice on the lower little bottom corner here, I've written testosterone in very teeny letters. And the reason I've written it in teeny, teeny letters is I wanted to acknowledge that it is a hormone or a type of hormone replacement that some people talk about around the time of menopause, but it is not pivotal to biologic function. So estrogen is why we feel better. Testosterone is used for some supplementation for women who are reporting a loss of libido, a decrease in sexual interest. It does not currently appear to have any other function postmenopausally, and it does have some risks. So all women, as they go through menopause, tend to have a little bit higher testosterone or male hormone level. Most women, as they get older, might notice a little mustache. And so this is something that people use with caution. Most women aren't, asking for testosterone. And the side effects of testosterone, if they happen, so if there's a little development of an Adam's apple or a lowering of the voice to a deeper type of male tone, these are permanent changes. When a woman stops testosterone, if these side effects develop, those changes cannot go back in time. So this is why I put it down little teeny. People may have read about it or thinking about using it, but it's not a common thing that should be considered for most hormone replacement patients. Okay, now I made this, I don't think it's called a word cloud. And the reason I wrote down lots of different types of names of hormone replacement choices is because depending on where you live in the world, you may have different names for the same medicine. You may not have access to all of these medicines. You may have access to medicines that are not listed here. Every country that you live in has slightly different availabilities. All of these things are used in different places in the world, and they're used, there's other names as well. So if you see one that you don't have available to prescribe or to you as a patient to use, don't worry. It just means it's not available where you are currently living. And the reason I put all the names up is I'm not going to give specific names with formulations. We're going to talk in general about types of HRT. So for medicines or for hormones to be delivered, there's many different ways. Most of us are pretty familiar with taking pills or taking tablets, but hormone replacement therapy can also be delivered vaginally, and this would be in the form of a cream, a pessary or ring, or a vaginal tablet. And hormone replacement therapy can also be delivered through the skin, so that we call this transdermally. This can be a patch that sticks on, it can be a spray, it can be a gel that you rub on. And in some countries, they do have a little hormone implant that is embedded under the skin that lasts for a couple of years. Each way of receiving or using HRT has good points and has bad points. So as I mentioned before, systemic HRT is something that a woman uses that goes through her whole body. So these tend to be pills or patches. This might be useful for some people because we said, of course, we have estrogen receptors all over our body. But we also have local HRT, so medicines or hormones that work on a really specific part of the body only. And these tend to be the vaginal preparations, the rings, the creams, the gels, or the tablets that go within the vagina. And we would choose these for different patients for different reasons. Okay, so oral. Most of us are familiar with taking pills throughout our life. What are the good points of using oral HRT? Well, it's pretty easy to use. They come in nice round or elongated package. They're very clearly labeled. They're very well studied. Almost all of the studies that we have for HRT that say whether it's safe or unsafe come from pill formulation. And most of the time you have your estrogen and your progesterone, your E and P combined into one pill. So you don't have to think about, okay, I'm going to take this pill, I'm going to use this cream, when do I take my patch off? It's really easy to use. And because it is made in a lab, it's a very consistent dose. The pill you take on Tuesday is going to be exactly the same dosing as the pill you take on Thursday, because every single pill is calculated and formulated within a laboratory. So it's a very consistent dosing from day to day. Now, what are the cons? So oral is a systemic medicine, right? It's going to affect your whole body. So it is metabolized in the liver, probably increases your cholesterol a little bit. You can get swollen breasts, which you may already have with menopausal concerns. You can be a little bit nauseated, maybe a slightly higher risk of blood clots, and possibly a higher risk of stroke, depending on when you started, how close you were to menopause, and how old you are. And people will say, well, maybe I'll just take only estrogen. I'm not going to take the progesterone because I'm worried. No, if you have a uterus, you have to use a combined pill that contains both estrogen and progesterone. You cannot just take estrogen. Okay, now there are different ways for oral hormones to be taken. So there's sequential, which means you take one and add another. And so how this is done is a woman would take the estrogen daily, and then the progesterone is used for half the time, so usually about 14 days. This results in a bleed that mimics a period. It's not really a period, but it's regular bleeding that we cause to happen about once a month. For patients who are younger than 50, who may have had a bit of an earlier menopause, but who are really struggling and clearly need something, some of these patients who are 45, 46, who are starting on hormone replacement, they want to choose a sequential because they want to feel normal. They want to continue to have a period. However, it's not necessary. They do not need to have this period. It serves no biological function other than feeling normal. The other way to use oral hormone replacement is continuous. So you take the pill every single day. There is no bleeding whatsoever. And this is recommended from the age of 50 onward, because most women at this point are not so interested in having periods. They would like to stop having their periods. They know if they do not take the pills, if natural menopause comes, they're not going to have their period. So this is usually when we recommend it. If someone a bit younger says, you know, I'm 46 now, I don't really feel like having periods, but I need these hormones, we can do continuous for those younger patients as well. Occasionally, a younger patient may have a bit of spotting because there's just enough of her own hormone left to try to have a little mini period. And if you just warn them, they might have a bit of spotting here and there. If they start continuously under the age of 50, it's perfectly fine. There's no adverse effect to doing it that way. Now, the skin. So the skin, which is the transdermal, so there are patches that go on the skin. Most of these patches tend to be estrogen only. There are some in the world called combi patches and Divel, which is a combi patch as well, which has estrogen and progesterone in it, but most patches are estrogen only. The pros of a patch is you don't have to take it every day. So you take a pill every single day, you got to remember to take your pill. A patch, you just change it once or twice a week, depending on the formulation. And the interesting thing about the patch is it bypasses the liver. It is not metabolized in the liver. It goes directly into the bloodstream, and therefore it does not increase cholesterol. There is likely a lower risk of blood clot or strokes for the patches that contain estrogen, but the studies on that remain ongoing. Now, what are the cons? So some people have really sensitive skin. The adhesion on the patch makes them really itchy. And then the problem with the patches is the dosing can be really variable. So, you're moving around, you're jumping around, you're chasing your kids, you pull your jacket on and off, so you can get the patch peeled off a little bit. Maybe you're getting less dosing during that time. Maybe you just have the type of skin that things don't stick too well. Some people are stickier than other people. And then if you're out hot, so in your hot environment, for example, Qatar, you vasodilate. So as you vasodilate, your blood vessels open. So you're going to get increasing estrogen dose. And then you go inside to the air conditioning area. It's so cold, you put on your jacket, you're actually cold. Your blood vessels constrict. So you're not getting any estrogen or less estrogen during those times. So the dosing can be really variable. Now, what happens to women is when they have a variable dose, those subtle changes of a hormone effect like mood disruption, irritability, they're more likely to occur when you have a dose that goes up and down versus a dose on the pill when you're getting the same amount every single time. The mood disruption, the irritability is less. And then the cons, of course, are very similar, that you can also have nausea and swollen breasts as well. And if a patient is using a patch that is estrogen only, and she still has her uterus in place, this patient still has to take an oral progesterone pill. There are not many progesterone only patches, and most women wouldn't want to wear like an estrogen patch and then a progesterone patch and have a bunch of patches running on their arms or on their tummy or on the back, wherever they're putting it. So a lot of women end up taking a patch, but also taking a pill. Some women don't mind this. Some women just find the extra job of taking two medicines in a different way just to be a little bit tedious. Okay, for the skin though, there is also, in addition to patches, there are gels, sprays, and creams. It's all the same. It bypasses the liver, probably does not increase cholesterol, reduces risk of clot or stroke. Now, these ones are popular because we see them in social media, TikTok, Instagram, but interestingly, they're not quite as well studied. And the dosing is probably even more variable for these because, of course, what happens? So women go to use the pump. Maybe they're just having a really exciting day and they give it a big pump, or they're like, oh, I'm rushing, oh, and they give themselves a little pump. So the amount that comes out of the pump can be variable. Again, people can have hot and cold skin. And depending on how quickly you need to get dressed after you put your gel or your spray on, you can rub off. It can be absorbed a little bit by your clothes. So some days you might be getting a lot, some days you might be getting a little. And then the other thing about the gels and the sprays is that it actually can be absorbed by others. So people who have smaller children, especially young female children, in the house still, they should be carefully counseled that, if your niece or your daughter, your granddaughter wants to come up and give you a big hug and you've just put on your gel or your creams, you actually, in a really safe way, you should be, wait, oh, please, let me get my jacket on, let me get my long sleeves on for you, because you can actually transmit some of that estrogen to people within your household or people within your community, which is something it's a very low dose, but why expose that risk to our younger children or our younger community members as well? So there are some issues with it. And then again, if you have a uterus, you still need to use progesterone. You can't just use your estrogen pump, your estrogel. You have to still use progesterone to prevent yourself from developing endometrial or uterine cancer. Okay, and then there are some vaginal rings. So these are different shapes. They're quite small. They go into the vagina, and they're interesting. They're usually called the S string. They have different names, but the nice thing about them is you actually just have to change it every 3 months. So you don't really have to remember to do anything. It's not like you take a pill every day. It's not like you're looking at your patch and you're thinking, did I put this on Monday or is it Saturday? When did I put my patch on? I can't remember. It just stays in place for 3 months. Now, these are incredibly effective for treating vaginal symptoms. And those would be symptoms for a patient or a woman who is saying, I feel very uncomfortable. My vagina is very dry. When I pee, it burns. I don't enjoy sexual activity with my husband, or I'm wiping and I just feel like it's really raw. The tissues are not comfortable for me. So local vaginal estrogen is really effective for treating vaginal symptoms. And because it works mostly in the vagina, the things that we would worry about for the whole body effect, so liver, blood clots, stroke, we don't think that any of those risks exist with the vaginal preparations, especially the vaginal rings. So what are the cons though? It only helps with local issues. So a woman rarely will complain just of vaginal concerns. Normally, she is concerned about vaginal issues, but she's concerned with not sleeping. She's concerned that her joints are hurting her. She's sweating at work. It has no effect on any of those things. It only works on vaginal concerns. And if we use a vaginal ring for years and years and years in a row, people wonder a little bit if that estrogen can move up into the uterus and maybe have the same progesterone issue that the systemic estrogen does. So we might need to add some progesterone to women who say, listen, I've been using vaginal rings for 5 years. I love them. They are solving all of my problems. Sometimes after 4 to 5 years, these are the patients we might say, maybe we should start a little bit of progesterone to make sure that that estrogen effect, although it's very small, has not been long enough to cause a problem with endometrial or uterine cancer for you. Okay, now vaginal creams and tablets work very similar to the vaginal ring. You only use them 2 to 3 times per week. Again, highly effective for treating vaginal symptoms, but really not effective for treating any other concerns. And the creams and tablets, although they work really well, some women will complain that the vaginal discharge can be like a little bit messy. Okay, so things can escalate quickly. And I just wanted to touch on, as we head into question time here, some myths and unresolved questions, and we'll move through these. So the myth, HRT causes breast cancer. No, all women have an increased risk of breast cancer with increasing age. Estrogen-only formulations do not increase breast cancer risk, but the progesterone and estrogen together maybe increases the risk slightly. But what I wanted to highlight here is this, is that all women, all of us have risk of breast cancer, but actually it's our lifestyle risk factors, being overweight, being obese, and drinking or being a smoker. These things, these women, the drinkers and people who are overweight, much, much more likely to get breast cancer than women who are on HRT. Women who exercise a couple of hours a week and women who take estrogen only actually have a reduction in breast cancer. Okay, so people think I'm going to get breast cancer. No, it's our eating style and our drinking style that are more likely to give us breast cancer. HRT cannot be used if someone in my family had breast cancer. That's not true. Yes, some types of breast cancers are genetically inherited. Everyone gets breast cancer. They are positive for the BRCA1 and BRCA2 genes. These people should definitely not take hormone replacement therapy. However, most breast cancer is not genetic. Most of us have no genetic risk for breast cancer whatsoever. We might be plump, have other lifestyle choices, and a single family member with breast cancer does not increase your risk of developing breast cancer if you choose to use HRT. HRT causes heart disease. The reverse is actually true. It actually reduces heart disease. And why is this? It's because our estrogen makes our blood vessels really stretchy. As we get older without estrogen, the blood vessels become really stiff. And as the blood vessels narrow, they can accumulate plaques, or they don't pump the blood to the heart as well as it should. A nice stretchy blood vessel is more likely to pump blood well to the heart and reduce risk of a heart attack or a myocardial infarction. And estrogen improves our good fats and reduces our bad fats. So actually, it is protective for heart disease. And then HRT causes blood clots and stroke. No, there is a difference between the types of HRT used, the tablets, the whole body versus creams and gel. But overall, the risk remains low for healthy, fit women, regardless of what type of medicine they're choosing to use. So HRT is better in bioidentical form. No, it's not at all better. People want to sell this. So it's formulated in private centers in general, and people sell them. Now, in fact, if I'm just mixing something in a lab, I'm not stringent, I'm not following any health controls of the government. Some days maybe I'm adding more, some days maybe I'm adding less, some days maybe I'm grinding it better. So they're quite variable, and there's no evidence that they are more effective. And why is that? If you look at the picture I put in the middle of the screen, this is actually a receptor on a cell. So all of our cells have estrogen receptors. These estrogen receptors just want estrogen. They don't know if it's bioidentical or regular estrogen made in a lab or the natural estrogen that I made. This estrogen receptor just wants the estrogen to bind on it. So the bioidentical hormones, it's a bit of a marketing issue, but there's no evidence that they're more effective. And there is lots of evidence that they are more variable in dosing. HRT will cure my vaginal dryness and discomfort. No. Some women on oral or transdermal HRT still experience vaginal dryness or discomfort with sexual activity. And for these women, you can add, or they can take, vaginal estrogen in small doses. And that estrogen, oral or transdermal, plus the vaginal estrogen, does not increase any of those risk factors or things that we would be worried about. Once I start HRT, I'll never be able to stop. No, this is not true. So yes, HRT doesn't stop menopause from occurring. What HRT is doing is it's treating the symptoms and signs that tell us we are going through menopause. Menopause is still occurring underneath all of that. Our natural estrogen is getting lower and lower. So when people stop HRT, they may have an uncomfortable couple of weeks when they're like, oh, I feel hot like I did when I was 50. It's coming back, it's coming back. No, if you gradually decrease HRT, those bad symptoms that prompted you to take it at the beginning tend not to return. And if they do return, it usually stops fairly quickly. So what we know now, vaginal estrogen is not associated with any increased breast cancer risk, even with a prior breast cancer history. Risks for any of the risks are reduced in lean women. There's no evidence that a dose of estrogen, like a high dose makes a higher risk or a low dose makes a lower risk. No, doesn't matter. Potential breast cancer risk is with HRT is less with HRT than lifestyle risk with obesity, alcohol use, smoking, and being sedentary. It is safe and effective when you start within 5 years of menopause, and do not start after the age of 60. This is what all the studies showed the risk was. What we don't know, there's lots of ongoing studies. So we don't know why there appears to be an increased risk of breast cancer when estrogen and progesterone are used together, which of course we need to if we have a uterus. Estrogen alone does not appear to increase breast cancer risk. And it's really unclear why estrogen alone may be protective, but the type of progesterone may be important, but there's tons and tons of ongoing studies, which hopefully, as you know, we hear the next few years moving forward, we will get more information about how to best to counsel our patients with this. So quick summary. So for menopause, yes, it remains complicated because we are complicated people. Individual treatment is necessary. The treatment choices may change based on a woman's symptoms as she ages, her concerns, her personal health issues. New information is always being released, so we have to be vigilant as ourselves, as patients, as well as physicians when we care for women in this age range. And personal choice is important. Some women may prefer to take pills. Some women may prefer to use a patch plus a pill. Some women may just want vaginal cream. All of these choices are an option, but we have to be able to talk to our patients and make sure that as a patient coming into the physician, you have an idea what would suit you or what wouldn't suit you. Now I'm happy to take about some questions, and I just wanted to put here some really reputable resources that you can log on to. The North American Menopause Society, the British Society, Menopause Center, Women in Sport, and FIGO have very, very robust and quite thorough and interesting components that you can click around and find lots of things about menopause that might answer some more questions for you. So thank you very much. I'm happy to take questions.
Great. Thank you very much, Dr. Huckell, for a wonderful presentation. If I could please request if you could stop share.
Okay, I'll do that now.
Thank you. Great. Thank you so much. You know, I think it was a great session. We've got some questions coming in. And again, there might be some questions that you've probably already answered, but sometimes, you know, we just like to reiterate those so that people are better informed. So just talking a little bit about menopause, I know there are many terms, you know, people just use like perimenopause, menopause, postmenopause. So can you maybe just talk a little bit about that so there's clarity in people's mind that what are all these terms that people are referring to?
Yes, well, I very specifically chose not to include that, but let me do my best. So menopause is actually easy. There's a really strict definition. When a woman does not have a period for 12 months, we say that this is menopause. Okay, menopause is complete. Now, postmenopausal is 12 months forward. This is postmenopausal. Now, perimenopausal gets a little bit tricky. So perimenopausal is someone who is having signs of hormonal changes. Her periods may become irregular. She may start having hot flashes. She may be like Where's my keys? Did I put the milk in the fridge? What's going on? These are perimenopausal changes, which can occur 8 to 10 years before menopause. And so the time frame for perimenopause is a little bit different. We use it kind of loosely, which is why a definition is hard to come by. And then the other thing about perimenopause is if a woman is 10 months without a period, and then she has a couple of periods, the 12-month clock has to start again. So those 10 months when she didn't have a period, in retrospect, we would know that she was perimenopausal around the time of menopause, but she never got to 12 months because her period came back. And so perimenopause is a little bit trickier.
Okay. Okay, great. Thank you for that. And just, just taking the story a little forward, again, just about the age. I know you did mention an average age and so maybe you can just please reiterate that what age can you start to have these symptoms?
Yeah, so the average age worldwide is actually 51. However, from the ages of, I'll say 45 to 55, these are still really normal times for a period to come. Now, the medical definition is really interesting. If you have no periods for 12 months and they never come back, at the age of 40 or younger, you are considered to have early menopause or premature. But if you go to the age of 40, and you do a year to 41 without a period, and we do some testing and your period never comes back, 41-year-olds can still be normal. So if someone said, oh, I stopped my period at 42, I was early. Actually, medically, she wasn't early. She was still within the range of normal.
Okay, great. So there's a question by an attendee about can a low TSH and a high free T3 and T4 cause bleeding post-menopause?
Well, the short answer is no. And what I mean by that is thyroid hormones certainly do affect female hormones. However, when a woman is at a point of her life when there should really be no female hormones left around, TSH by itself or T3 or T4 should not bring on a period. Like we could just keep feeding a woman T4, T3 when she's 60. This should not start a period because there's no underlying female hormones to cause the lining of the uterus to thicken.
Right. Okay. Thank you very much for clarifying that. So we have another attendee, says I'm 46 years old, period stopped last October in 2023. Prior to that, menstruation became irregular and I have hot flashes and dryness. So are these menopause symptoms?
Yes, they're definitely menopause symptoms. And this is the problem is some people just get one or two, but these sound like important ones, but some people get one thing and they're not sure, or some people get everything and they're definitely sure. But it's the questioner, it's the right age at 46, the time frame with the spotting and the prolonged lack of periods and the other symptoms is definitely menopausal symptoms for sure.
Sure. So again, there are some questions, sort of asking about a risk of something, is that related? So I want that clarified also. So there's one question, if there's an increased risk for type 2 diabetes, during perimenopause or menopause.
Yes, there definitely is, but it's not menopause as a medical entity that causes that. It's that around the time of menopause with hormone changes, we all tend to put on some weight, a couple kilograms here, and it tends to be the tummy weight. So all people, male and female, as we get older and we gain weight, have a higher risk of diabetes, but it's not menopause that causes that, it's the weight gain.
Yes. Okay. So that's very important to understand that it's not the menopause causing that. So again, a question related to, again, how people associate certain things, or they hear, maybe at a certain point in life, one thing happened along with men, and then they sort of start associate. Yeah. So is there a link between a frozen shoulder and menopause? Then one of our attendees says she knows many women, who started this problem of frozen shoulder and they were diagnosed with their gynecological disease. I'm assuming she just means
So around menopause, we do get more joint pains. We tend to be less stretchy, less bendy. And people who have particular types of shoulder joints, we know that the bigger joints, the joints in the hips, tend to stiffen a little bit more around menopause. So potentially frozen shoulder or stiff shoulders would be more common with a decline in estrogen and progesterone.
Okay, okay. Okay, so thank you for answering that. So a question about, one of our attendees started menopause 2 years back, and she's asking, will it get better with time? So I'm
Yes.
assuming she's talking about the signs and symptoms.
Yeah. And so this is why we know it gets better with time. And this is why we normally will use hormones for a while. Most women after 3 to 5 years will think about discontinuing. And we usually do try discontinuing because menopause gets better over time. And so we're helping with the really bad symptoms until the underneath menopause issue has kind of sorted itself out. If you go back in time, many of our mothers and grandmothers, great grandmothers, they didn't use hormone replacement and they were fine as they got older. But the duration, so whether it will resolve in 1 year for a person or whether that's the poor lady who's going to have like a 10-year experience, we have no way of predicting. Only the patient herself can report, doctor, it's been 5 years and it's just as bad now as it was 5 years ago. We don't have any tests that tell that, but it gets better for everyone. It can be a year, it can be 8 years, but it's still normal.
Right, thank you. And just sort of taking that a little forward. So is it really recommended to take HRT, if signs and symptoms are not as severe, not really affecting your quality of life? What is the best recommendation?
Yeah. And this is why it gets back to the individual choice. Menopause is not, as I said, it's not a disease. It's not an illness. It's really normal. The problem is we just live so long now compared to the past. And we want to live well as we get older and, be with our great grandkids and all of that stuff. So it's not recommended. If a person is not struggling with any of those signs and symptoms, she's feeling well, she's like, oh, I didn't have my period for a couple of years, I feel fine. We do not recommend HRT to these patients. They don't need it at all. But if there is symptoms and the individual wants to choose that, then we're happy to prescribe the HRT, or we should be happy to prescribe it.
Okay, thank you. So there's another question about with reference to an IUD, the intrauterine device. So is it advisable to keep using an IUD for local hormonal management of menopause symptoms, and for how long?
Yeah, so just to clarify a little bit, and I didn't include this in the talk, but there are 2 types of IUDs. There's an IUD that contains copper. This is just for not getting pregnant. There is an IUD that contains progesterone. This is for not getting pregnant, and it protects the lining of the uterus from not getting endometrial cancer. So there are definitely women, they will have a patch or they want to use the estrogen cream. And they're like, but doctor, I don't want to use a cream and take a pill. What can I do? So for those women, we will put in a progesterone IUD. In this region of the world, that progesterone is called a Mirena. It's the brand name is the Mirena. It has different names elsewhere in the world. So if a woman says, you know what, I'm willing to have a Mirena IUD because I don't want to do 2 things. I just want to use my patch. We definitely will put a Mirena in so she does not have to also take the progesterone. And the Mirena is good for 5 years and it protects against that endometrial cancer that we worry about without using progesterone.
Okay, and again, the Mirena is of course for, progesterone, right?
It's progesterone, yeah.
And then even if these women, they have additional signs and symptoms, then they could also be taking the estrogen for as hormone replacement.
Yeah, exactly. They can still use estrogen.
Yeah, correct. And also, if you can talk, I know you did say, there are very few women who would have their uterus removed, but due to maybe some conditions, that these women who've had their hysterectomy, the uterus removed, because people get confused that, okay, I don't have a uterus now. Am I really going to get, am I going to get menopause, or what are all these symptoms that are still coming to me? So yeah, exactly. If you can talk a little bit and explain that, for women.
So the most common way that a woman says, oh, I'm having menopause or I've had menopause is she noticed that her periods disappeared, right?
Right.
Menopause is not just that your periods disappeared. So if I do a hysterectomy and I take away a uterus, definitely your periods are going to disappear. But if I do that hysterectomy at say 25, okay, and you stop having periods, you are not menopausal because your normal hormones still exist. So all
Sure.
of the tissues and organs in our body that like estrogen continue to like estrogen even when the uterus is removed. So people
Right.
who have had their uterus removed, their signal that they stopped having their periods doesn't count for them. They would be the ladies who'd be like, oh, I'm so hot and I'm flushing, I can't sleep, and my joints are
Yes.
sore, I'm so tired all the time, and I
Yes.
forgot where I put the groceries. So these are women who have different signs and triggers or signals that menopause is coming or has come.
Mhm. Great. Thank you for that clarification. So we have another question. There was one of our attendees. She was diagnosed with premature ovarian failure when she was 36, did
Mhm.
not take HRT, had a past history of DVT in the upper limb, and now suffering from all signs and symptoms of menopause. She's 48 now. What treatment can be used, especially for vaginal dryness?
Yeah. So this patient, I'm sorry to hear that it was a little bit early for you. It is definitely difficult because we worry, of course, about DVTs and all of these things for people. There are some of the other medicines that I briefly put up on the other slide. So the systemic ones, the ones that you would take a pill, there's a medicine called clonidine that may help, and some of the antidepressants may help. But if the only issue is really vaginal discomfort, pain with urination, sexual activity, then any of the vaginal estrogen preparations, the creams, the pills, the pessaries, the rings, any of those vaginal preparations are safe, even if a person has a history of DVT, a history of breast cancer. They're all safe because they work just mostly in the local tissues. They don't work on any of the other tissues.
Mhm. Great. Is it okay with you if you ask a couple more
Oh, I'm happy to
questions?
keep going. Yeah, don't
Okay,
worry. I'm totally fine.
great, great. Yeah, so I think because this is such an important topic and people don't get to talk about it often. So I think it's very important that we
Mhm.
address it. So can menopause affect mental health? I know you've referred to bone health and a lot of the other
Mhm.
things. Does menopause affect mental health?
Yeah, so we know there's many, many studies that there are estrogen receptors in the brain. There definitely are. So it kind of makes biological sense that if you have estrogen receptors in part of your body and then there's less estrogen, that probably something is going to happen. However, when we are doing cognitive studies, like how do you tell if someone is not thinking well because maybe they're not sleeping well, or they're not thinking well because they just got older and they're not going, they've retired, they're not so engaged with accomplishing things at work anymore. So that part of the brain kind of gets a little bit softer, a little bit looser. So it does appear that there is some link to cognition, to thinking with menopause. So people will talk about menopause brain and all of that type of thing. And some of the studies, ongoing studies, do show that maybe using estrogen for a while around the time of menopause will delay or push back dementia or push back Alzheimer's. So clearly it shows there's some brain estrogen link there. The problem is that no one knows specifically. So what is the risk of changing thought process around menopause? Because we all have women in our family who are, 80 years old and still sharp as a tack. Your
Yes,
great aunt or your grandma is going to get you, and that woman has no problem whatsoever.
sure.
So we don't know the extent of who it affects, how much it affects, and even how to predict what might be an issue for some patients.
Sure, great. And I think that's very important for all of us to understand that each woman is unique and
Mm,
you have to sort of see what she's going through.
mm.
Um, Another thing, of course, if you can talk a little bit about, as women are going through menopause, what is it that family members can do, to support women? I think that there's a big stigma attached in
Yeah.
societies, to talk about this and just be aware about this. People don't, maybe the men don't want to hear about it.
Yeah.
So what advice can we give to them, other than, of course, be better informed? How is it that they can support women through this, stage in their life?
Yeah. Well, I think, of course, within each individual family, the answer, the solution might be a little bit different. But I think sometimes making things more simple will help. And what I mean by that is if someone in the family had a broken leg. Okay, we can see that that person's leg is broken. They need help
Yes.
until their leg gets fixed. So perhaps drawing an analogy to say to someone, listen, I don't have a broken leg, but my hormones are not working right now. I need to get through this. And it's not going to be a forever sort of moment, just like a broken leg doesn't last forever. The person that the woman is trying to educate or trying to talk to may have a better understanding that it is a medical issue. It's a medical disease. It's not just that, you know, maybe she got old and grumpy. It is not that. It is a medical concern. And so maybe drawing an analogy to something like a broken leg would help. And
Yeah.
then the other thing I think that is being proactive and saying specifically what they would need, because sometimes people say, well, I need help. And then you're like, well, what help do you need? And the person, whether it's your family member or patient, will be like, I don't know, I just need help. And then you're lost, right? I want to help you. What do I do? So sometimes
Sure.
concrete things are like, you know, every Thursday, you have to go buy the eggs and milk because I'm not going to remember. It's your job. Or, you know, I need you to, you know, always, you know, go pick up the kids or the grandkids on Saturday morning when we take them from our daughter because I'm going to forget, or I need extra time in the morning. That is now your new task. So being specific to the help that is needed, I think makes it easier for people around to help.
Sure. Thank you. So I think we can, I'm just going to ask you the last question
No
now.
problem.
What are some lifestyle changes, that we can do, which can help,
Mhm.
basically manage menopause better, for us? Let's end on a positive note,
Yeah.
and also, where we can basically take control, somewhat in our hands and sort
Yeah.
of say, okay, we are empowered and we can do this, and this
Yeah.
will help us through.
Yeah, well, if you think back to, I think I put a slide up about increasing breast cancer risk with obesity and, you know, smoking. Down the other column, there was people who only exercise twice a week. Okay, so reduce their risk of breast cancer. And this
Right.
is actually linked to improved menopause as well. So just a little bit of exercise, it keeps our joints bendy, keeps us limber, and part of the brain moving around. So when we're jumping around or walking or moving, the brain has to function in a different way. It's called joint position sense to keep our muscles functioning. And so our brain, although we're not like, reading physics textbooks, our brain is still working to keep our muscles in alignment, to keep our muscles working. So even just going for a walk outside after dinner when it's a bit cooler, a couple times a week will really help with that. And then we all know, whether we are young or old, we all know that we make food choices that are not ideal. And so
Sure.
when you really like bread and pasta and rice when you're 25, that's okay. But those sorts of things as we age, and especially around menopause, the weight sticks on much more. So not necessarily go on a diet, but just think, okay, instead of rice 3 times a week, I'm just going to do it once a week. I'm not going to have pasta every weekend, or, I'm going to cut down on my bread. I can have my sandwiches I can have an open face sandwich and only do half a bread, or whatever we do. So just making those small changes, I think will make a big difference to, first of all, how our body responds to menopause, but also how we're going to feel as well.
Yeah, I think those are all great points. Just one last question, because
Of course.
people do tend to ask, so I wanted answered, if you can, please. So just, I know you spoke a little bit about herbal supplements. So
Yes.
people always like to start with, non-pharmacological.
Mhm.
So if you can talk a little bit, if at all there is evidence, if at all there are herbal supplements which can help, so, our community is better informed.
Sure. So there have been throughout the years many, many studies on herbal preparations, and
Yes.
occasionally they seem to show an effect, and occasionally they don't seem to show effect. There is two. One is called black cohosh, and one is called red clover. That there are repeated studies on these two herbal preparations that show they may help a little bit with the hot flashes. Okay, they probably make no difference to insomnia, to thought process, to joint pains, but they might help with the hot sweatiness that some of us encounter at work and, just living our lives. So those are the two that might be effective. There are many, 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 many formulations you can find on the market, and most of them probably don't affect anything in a significant enough way to really make us spend our money on it.
Right. Yeah, thank you so much, because again, like you're alluding to, there are so many of these herbal preparations and formularies, available in the market over the
Mm,
counter. And there's
mm,
so much conflicting information available even on the internet, right?
yeah.
So online. So it's sometimes very difficult for people to understand what is the right thing to do, what is the right thing to choose in these circumstances. But thank you so much, Dr. Huckell.
Thank
Excellent
you.
session. Yeah, it went very well. So really thank you for giving us this time and to make time from your very busy schedule. So thank you again very much. We would like to thank all our attendees, who've joined us today from different parts of the world. We are grateful to them for attending, and we look forward to seeing many of them at our next iterations. So thank you again, and bye-bye for now.